Hello, everyone. Greetings from Geneva, Switzerland, and the United Nations Institute for Training and Research. It's wonderful to have everyone here. We're just going to let the participants join in and give a few more minutes for all the participants to join the call. I can see the numbers jumping up quite quickly, and we'll get started right away. All right, well, let's get started. It's a pleasure to welcome you to this session on breast cancer improving outcomes in low resource settings. My name is Jeff Ibbotson. I'm the executive lead at the Global Surgery Foundation and also at UNITAR, senior health advisor. And we have a very exciting discussion today, a wonderful panel, and I don't want to take too much time to take up the time talking, but I'd like to introduce Oluwatu Lashabani, and who is going to be our moderator. And I'm really looking forward to the discussion. We've planned this as more of a discussion versus just a series of talks. So with no further ado, I'd like to turn it over to you, Oluwatu. Thank you very much.
Thank you, Jeff. Thank you very much. Am I audible? Can you hear me? All good?
all good. Wonderful.
All good. So don't just survive, thrive. That's really what I think about, Jeff, when I think about today's conversation. It's one of my favorite quotes about, like, don't just survive out there as you move through the world, thrive. And one of the things when I had a chat with a friend of mine who had breast cancer, she was like, I survived, but I am not thriving. I'm really struggling right now. So this is what sparked my interest in today's conversation. And as soon as I got that mail that asked me to moderate today's session, I was like, I am totally in. So I would like to thank you firstly for affording me the honor of holding today's space for the conversation that we're going to be having. And with all protocol observed, respectfully and fully, I'd like to welcome everyone in civil society. I'd like to welcome our government officials and representatives that we have today present with us, as well as personnel from nonprofit organizations and private sector at large. And those that are impacted or interested in learning more about breast cancer, surgical care, and health systems being strengthened. I am Oluwatu Lashabani, and I'll be moderating today's session and the conversation that we're going to be having on all things breast cancer. Today, as we talk about all things breast cancer with a particular focus on the role surgical care plays in breast cancer care, as well as patient-centered approaches that can improve health outcomes for breast cancer patients. We are going to unpack this with a panel of experts, as well as a guest of honor, Zozibini Tunzi. Now, breast cancer continues to be a major global health challenge, claiming the lives of more than 685,000 women in 2020 alone globally. The World Health Organization estimates that almost 50% of breast cancer cases are in developing countries, countries such as mine, South Africa, countries such as Argentina, India, China, Brazil, to name a few. The growing disease burden of cancer in low income and limited resource settings is a clear call for action to improve the health outcomes and increase access to treatment options. Surgical care is the foundation of the treatment options for breast cancers and has been proven to be highly effective, especially when disease is diagnosed early. So with October being Breast Cancer Awareness Month, with the annual campaign being set to increase awareness for the disease, and the UNITAR, UNITAR, as well as the Global Surgery Foundation joining forces and hosting this webinar, let's delve into the conversation and ask the pertinent questions. How can we improve health outcomes? And how can we continue to improve access to treatment in low income and resource limited settings? So without any further ado, I'd like to step into our panels and our guests of honor. I'd like to firstly welcome Ms. Zozibini Tunzi, Miss Universe 2019. With the longest reign in the history of Miss Universe, Zozibini is a leading woman who has carried us through the pandemic as we took up space and showed the world that we as women are the beginning and the end and the all-encompassing. Zozi is a public relations management graduate, and at the time of winning her titles, Miss Universe and Miss South Africa, or firstly Miss South Africa and then Miss Universe, she was completing her BTech in PR at the Cape Peninsula University of Technology, whilst working full-time in an undergraduate program at a communications agency in Cape Town. The world is her stage and it is her oyster. And her goal is to reach and impact women and youth around the universe. To that end, Zozibini embraces her digital savviness to garner support and engage some causes and her causes and interests through her social media channels that attract millions of subscribers and followers, friends and communities, touching lives and creating important conversations. So Zozibini, welcome to today's conversation.
Thank you so much, Oluetu. I'm very, very happy and excited to be here today.
And before I proceed to our panel of experts, I'd like you to just give us some opening remarks and, you know, some tidbits on the impact of breast cancer within the communities that you are in, you've lived in, you're from rural Eastern Cape. I mean, we've seen it all. We've seen how stubborn our mothers can be in getting those annual checkups. So let's open up with some of your opening remarks.
Thank you so much. As Oluetu introduced me, my name is Zozibini Tunzi. I am born and bred in rural South Africa. I am a former Miss Universe and I am an advocate for women. I love women. I believe in women. I believe that in order for societies and the world to move forward, women need to be taken care of. They need to be seen, they need to be heard, and they need to be protected at all costs. Women are the backbone in which communities are built. And so when they suffer, you know, things are guaranteed to fall apart. This is why it breaks my heart that breast cancer continues to be a major global health challenge, with an estimated 50% of breast cancer cases being in developing countries. Now, I'm not a doctor, nor am I a professional healthcare worker, so I will not be speaking about technicalities of breast cancer. But what I do want to speak about is the human element and experience. Surgicalcare is the foundation of the treatment options for breast cancer and has been proven to be highly effective, especially when the disease is diagnosed very early. So why is it that we are still seeing this staggering high breast cancer mortality numbers in developing countries, especially Africa, to be specific? And I can give you a little bit of an idea. As Oluetu mentioned before, I grew up in rural South Africa, and I've seen firsthand how terrible healthcare systems are in low-income areas. From scarcity of resources and facilities for treatment, long distance traveling, as well as cost of care. I will go as far as saying that people from places like where I come from have lost hope in the healthcare system. They do not believe that it is a place of healing where their lives can be saved. There's even an ongoing joke where I come from, and I use the word joke very, very lightly, about the hospital that we have surrounding in our villages. It is said that if you go into that hospital, you do not come back. It is a place where people go to die. Their refusal of going into these hospitals comes from a lack of resources, from crowding and understaffing. It is in these forgotten parts of the world that we continue losing precious lives that could have been saved. It is for these reasons that, among many other things, women delay seeking medical care that they need until their tumors are advanced. To add on to that, there's also an element of education and information that comes into play. Most women in rural areas and low-income communities do not even know that if they are diagnosed early and have access to surgical removal, that they have a better chance of full recovery. In fact, a study reported that 25% of Africans still believe that cancer has no cure. And I know this firsthand. I've had conversations with these women where if they're found to have cancer, they believe that it is the end and that nothing else can be done about it. So then maybe it is time that we go back into those communities and speak to them in a language that they understand. A time to stop treating them like statistics and show warmth and humanity. We must continue to place patients at the center and support them through each and every step of their journey, because this goes way beyond diagnosis and treatment. It also the impacts are felt by their children, their families, and communities. And so I want to take this opportunity to remind everyone that most African homes are in fact headed and led by women. And so a loss of a woman is a huge blow to society. So this call for action is a very clear one. And this is why I continue to do the work that I do for women and girls in the huge platforms that I have. We must continue to use our voices and raise awareness on the disease that continues to take the lives of women and girls, not only during Breast Cancer Awareness Month, but beyond and always. Thank you so much, Olit.
Thank you, Zosie. Thank you so much. That is so true. I think about, the mothers that were the heartbeat of the homes during the pandemic, and the mothers that refused medical care because they thought, like Zosie mentioned, hospitals are a place where I go to die. So in today's conversation, we're going to unpack further these particular touch points, these sore points within our societies. And in introducing our panel of experts, I'd like to start with Dr. Benjamin Anderson, World Health Organization NCD Department. Dr. Anderson is Professor of Surgery and Global Health Medicine at the University of Washington. As Surgical Director of the University of Washington Breast Health Clinic, Dr. Anderson's cared for patients with breast health issues and diseases from 1994 to 2020. Dr. Anderson has worked internationally in global cancer control for over 2 decades, with joint appointments at the Fred Hutchinson Cancer Research Center Division of Public Health Sciences and the UW Department of Global Health. Dr. Anderson chaired the Breast Health Global Initiative, which pioneered the development of resource stratified guidelines in low and middle income countries. In 2020, Dr. Anderson joined the World Health Organization and now serves as the World Health Organization Medical Officer leading the Global Breast Cancer Initiative, launched in March 2021. Ben, you also have a very keen interest in travel, so hopefully we'll see you soon back in South Africa at some point. But Dr. Ben, before I hand over to you to tell us more about the Global Cancer Initiative, how can we contribute to more comprehensive treatment and supportive care? And then you'll delve into the Global Cancer Initiative, Global Breast Cancer Initiative, pardon me.
Well, I'd like to begin by commenting on Ms. Tunzi's words. She could not have been more on target with the essential aspects of how we improve this, because this begins with a patient-centric model. It begins with bringing women into this environment. And when we talk about the Global Breast Cancer Initiative, I'll walk through that, because that's very much embraced by WHO. Those are issues of awareness and understanding and misconceptions, cancer fatalism, the belief that cancer is invariably a death sentence. These all work against us. And so the communication that we're doing today, I think, is really essential. Would it be okay if I went into my slides now?
For sure, jump right straight into it.
So the Global Breast Cancer Initiative was launched in March of this year on International Women's Day. And this is the WHO's first major foray into breast cancer. The background is really important to understand. As you've already said, breast cancer, it's now the most common cancer in the world, taking men and women together. And it is the most likely reason of a cancer to take a woman's life. There are more disability-adjusted life years lost to breast cancer than any other malignancy. So it's really important that we be thinking about this now. And as you've said, the majority of cases and deaths are already in low and middle income countries. This idea that it's really just a high income country problem is a fundamental misconception. The problem is getting worse. By 2040, 60% of the projected 3 million new cases per year and 70% of the 1 million new deaths per year will be in low and middle income countries. There's this huge range with how we do with breast cancer globally. So 5-year survival is 90% in high-income countries in Western Europe and North America, but it's 66% in India and 40% in South Africa. And so there's a clear issue of disparities here. But I would turn that upside down and say this is also a statement of opportunity, because it's a demonstration that we know that there are things that we can do. We have been successful. Mortality has dropped by 40% in North America since the 1990s to the present time, and we can address this. But if we look at sub-Saharan Africa, this very important study, the age at diagnosis, because the population is younger, is a young age. Half of the deaths are occurring in women under age 50. And if you look at every 100 of those deaths, there are 210 children to become maternal orphans. So this is not only a social problem, a financial problem, a cultural problem, this is a generational problem. And therefore, we must address this today. Primary prevention is ideal. There are things that we can do to reduce breast cancer development. So being fit, weight control, avoiding excess alcohol, more lactation. These are all good things to do. And indeed, there are a lot of non-communicable diseases that this would affect. Cardiovascular disease, lung disease. There are a lot of reasons to do this. But if you ask what fraction of breast cancers would be eliminated potentially by this, it's maybe 20%. So there's still at least 70% of breast cancers that are going to happen anyway. And that's why we have to get into this combination of early detection and treatment. The objective of the Global Breast Cancer Initiative is to reduce breast cancer mortality globally by 2.5% per year. That would save 2.5 million lives over a 20-year period. There are 3 pillars: early detection through education, timely breast diagnostics, and comprehensive management. And really, this is a marriage between public health sciences, where we think in terms of populations or countries, and clinical management. How do we actually do this? Because that 40% improvement, that happened through clinical management using tools that today are considered standard. So the curves that you see on the left here, these are how breast cancer mortality has dropped in these high-income countries. And the goal is to translate this to low and middle income countries. That drop was between 2 and 4% per year. So when we talk about a 2.5% drop per year, that's not a fictitious number. That's been done with standard tools. But it's going through what we know about breast cancer. And we do know a lot because it's been so common and because we have good studies. The patient interval when she first presents, the diagnostic interval where we sort out who has cancer and who does not. And that's a really important part that's often overlooked. And then the treatment and management side. And so let's just look at that very briefly. Ideally, we need to get early stage disease because that's where we do well. And in fact, if you look at those countries that have been successful, at least 60% of their invasive cancers were early, stages 1 or 2. We had a publication that came out just last week that shows this with very strong evidence. This is an educational initiative, as you've been talking about. So we need to educate women that why it is you'd come in, what it is you're looking for, and the benefits that can be brought about. But you also have to educate the providers, because if the providers have never seen an early breast cancer, they don't recognize it, they won't know what to do. And we have to be able to connect not just to the primary care providers, but to the available district level facilities where diagnosis can be made. So educational initiatives at both the public and health systems is a fundamental goal of WHO. We need to have timely diagnosis because it's very common that patients wait. Not just they wait before coming in, but then the system delays. And that's something we have to address. Delays of 9 months, more than a year. We want diagnosis to be made within 60 days and to initiate treatment. If you ask why 60 days, at 3 months, our studies have shown that's where you start to see dropping survival. It's not huge, but 2 months, you want our systems to be able to do this. Having rapid diagnostic units, using ultrasound, as you see here in Rwanda, or a pathology laboratory that was formed in Kumasi, Ghana, using standard technology for pathology or leapfrog technology. We're looking at new tools that we can implement, and in fact, perhaps implement them first in low and middle income country settings, bringing them to high income country settings. Patient navigation. How does the patient make her way through? We need to navigate, not just send them to another hospital. And this is a fundamental need, not just for breast cancer, but for all diseases. Consider this example from Tanzania. We went and did a situation analysis and found that When the woman presents at that primary health facility, the first in these pyramid systems where you refer to one level up, it wasn't until the fourth level that a needle biopsy could be performed. So the woman would have to be referred 3 times to increasingly distant areas. Now the Tanzanian government understands this, and they're working on making biopsies more available, key to early diagnosis. So this is balancing between centralization. Some things we need to centralize to maintain quality. A lot of those treatments that you were talking about fit there, but other services we have to decentralize to make them available. And that stigma issue, that has to be addressed at the same time. In terms of treatment, we know a lot because of what has happened and what has been studied, whether it be a regional cancer center in Peru or Tata Memorial Hospital in Mumbai, India. And this management, comprehensive breast cancer management, we want to get the women all the way through the correct treatment, and it has to be adapted to her disease needs. And abandonment, that's a term, it doesn't mean the woman is just forgotten to come. We abandon the woman and they leave early. That's the worst of all worlds. If you start treatment but don't finish it, you get the side effects without the benefits. So this is where timely access, it's surgery and radiation and systemic therapy. It's not just surgery, although surgery often plays a leadership role, particularly in the early stages. We have to have patient navigation. We have to measure our outcomes. This is a primary goal for WHO. But as you've been referring to, we cannot forget about the woman after she leaves the system. She has to return home to a community that will accept her. We have to avoid the financial toxicity that is sadly so common. And we have to have support for her, that survivorship issues. That's what you were referring to. The woman feeling abandoned and feeling as if she made a mistake to go through the therapy that actually likely was curative. So survivorship and supportive and palliative care are all critical. In summary then, the UN now has mandates that include breast cancer and putting it on the global agenda, setting the stage for change. Breast cancer is a core index malignancy, meaning if we can do breast cancer, there are a lot of cancers we can do. We're not picking between diseases. We need to have that early diagnosis. And this is not necessarily use of mammography, especially when women present with very advanced cancers that you can easily feel or see. But we have to have effective treatment. We'll talk about that. But we believe that the Global Breast Cancer Initiative can be a catalyst for change by developing approaches that are relevant to women's cancers and women's health throughout the life continuum. Thank you very much for the opportunity to present to you today.
Thank you. Thank you. I mean, just by looking at that, the Global Breast Cancer Initiative, the pillars and the targets, we can already pick up on a few things that I think we're going to talk about it later on the trickle effect, the policies and how they come into effect on a ground level, how they come into effect in our lived environments around us. And we're going to tap into that with Many. But before I go to Many, I'd like to just also welcome and wish a good afternoon to Phumzile Mlambo-Ngcuka, who has joined us. Thank you so much for joining us on the stream. We see you and we value you. So let's proceed to Dr. Lynetta Coppert from the H2O program. Dr. Lynetta Coppert is an oncology surgeon based at the Rotterdam Erasmus University, who has a special focus on diagnosis and treatment of breast cancer and heads the Academic Breast Cancer Center. As a leading oncology researcher, she supervises multiple PhD students and focuses her main research topics on the quality of breast cancer surgery and development of a value-based breast cancer care, especially in young breast cancer patients. Since 2020, she has been involved in the European collaboration project, Health Outcomes Observatory, H2O, in which, amongst others, breast cancer is a focus for the development of a European outcome measurement data platform with a focus on patient-reported outcomes. Lynetta, could you please tell us more about what H2O, the Health Outcomes Observatory, sorry, my South African accent kicks in there so strong and hard, and how it can be translated into different contexts?
Hi, yes, of course, I would like to do that. Hi, everybody. Well, H2O, it's a new public-private consortium, actually with the overarching goal to deliver outcome-driven care. That's how we call it. So as well as clinician-reported outcomes, but also as well as patient-reported outcomes. So questions, outcomes concerning this quality of life. While partners in this huge project are clinicians, but also researchers, life science and industry. And together we aim to generate an, so to say, ecosystem to generate and implement outcomes into decision-making in clinical practice. And amongst the diseases within H2O is cancer. And amongst cancer, there's breast cancer. So while the European Union assists research and development through different funds, amongst which the IMI, Innovative Medicines Initiative. And so H2O is a IMI-funded initiative, a huge initiative. And you ask me, well, translate into different contexts. Well, the data platform we create is developed now in 4 countries, which is Spain, Germany, Austria, and also the Netherlands. And what we aim for actually is having outcome sets for 4 types of cancer, amongst which breast cancer, but also chronic diseases such as diabetes and inflammatory bowel disease. And besides standardization on outcomes, we will focus also on implementation, so important. And in the end, have kind of a pan-European platform for outcomes. And then we should ultimately be able to do prediction on outcome, maybe also for individual patients, scaling up in number of diseases, countries, and as much patients and healthcare providers as possible. That's our ambition.
And I mean, we understand that with the measurement of data and having these platforms, especially with the focus on patient-reported outcomes, this informs a lot of our policies and informs also the funding as well as the donors, where they come from, how they contribute. So to talk more about this and to really help us shed a light on policy, that donor funding, and to ask all those questions on that trickle-down effect, we have Mrs. Meni Stiliado, who is the Takedo EU CAN, VP Head of Public Policy and Healthcare Sustainability in Europe and Canada, Takedo Pharmaceutical Company Limited. Meni joined Takeda in 2015 as Head of Public Policy and Government Affairs for Europe and Canada, EU-CAN. Her focus is to help Takeda take advantage of public policy trends and create win-win business models for society and the company. In this context, she has to pioneer the creation of a triple P between healthcare industry, healthcare providers, and public sector to leverage digital technologies in order to create transparency of healthcare outcomes and improve the efficiencies in healthcare. Prior to joining Takeda, she worked for 9 years for Novartis in several roles in public policy and ethical leadership. Meni started her career in the European Commission in 1991 as a legal expert focusing on telecom law and policy. She studied law in Greece and Belgium and specialized in antitrust law. Meni, thank you so much for joining us for this conversation today.
Thank you. And thanks very much. Thanks very much for this very nice introduction. So, I think the key message I would like to share is about the importance of patient empowerment. So, and that has been very much at the core of the thinking around creating also the H2O approach that Linetta has so nicely described. And I think what you said at the beginning, that it's not about surviving, it's about thriving. It speaks so much to my heart. And I really want to thank you for this, because I will now always refer to this as a great way of describing what it is we're trying to do. So if we want patients not just to survive, but to thrive, in particularly when it comes to women, which are such a bedrock of our civilization, and we now see this again and again, that when women suffer, the society suffers, then we need to give them a voice that can be heard. And frequently, what happens with patients is that their voice is not being heard. And it is not being heard because it's not structured. There is a lot of pain, there is a lot of suffering, but they don't know how to make it understood by the healthcare providers or by the society. And since their voice is not heard and understood, then resources are not necessarily focusing on what matters to patients. So creating a structured voice that allows patients also to say what matters to them, it would give us the ways to know where to focus as a society and how to allocate our resources better. In my work, I often talk also to potential donors, I mean, as you've mentioned, and policymakers. And frequently, the one thing that always people say is that it's very clear that we're not going to resolve the problem of breast cancer in developing countries, or for that matter, in any country, without resources. But we need to be very, and resources are limited in any society, and so, and of course, they are very limited in the developing countries. So how are we going to find out where to best allocate our resources? And I think creating transparency of outcomes and creating a mindset of continue measuring the outcomes, but also listening to the patients, listening also to the broader community as I start, because sometimes it's not just the patients, but it's also the family around the patients. And capturing their voice in a structured way is something that will also make the donor community get a reassurance that the money or the resources are targeting what matters most. So that has been very much the work that also UNITAR is leading in the project we are doing in Europe, which is how to create this structured way of understanding the patient's experience or the patient's journey in the case of breast cancer, so we can give the patients a way to communicate with the healthcare providers and the society, and being able, hopefully, create better transparency of the pain and the burden of the disease, and in that way make it so obvious to donors that this is a public health public health emergency, and this is how their money and their resources will be better spent.
And I think to also just shed light on the lived reality and just also the on the ground of being in a developing country and specializing in the breast surgical oncology space. Let's welcome Dr. Miriam Mutebi, who is the Assistant Professor in Breast Surgical Oncology at Aga Khan University Hospital. Dr. Miriam Mutebi is a breast surgical oncologist and Assistant Professor in the Department of Surgery, as well as a clinical epidemiologist and health systems researcher at the Aga Khan University Hospital in Nairobi, Kenya. She is the Vice President of East Africa of the African Organization for Research and Training in Cancer, Chairperson for the Kenya Society of Hematology and Oncology, and on the board of directors of the Union for International Cancer Control. She is the co-founder of Pan-African Women's Association of Surgeons, which you can be found on www.africanwomensurgeons.org, that provides mentorship for female surgeons and is part of the Kenya Association for Women Surgeons. She's currently pursuing a private pilot's license in order to disseminate breast services to difficult to access areas, and I love it. Hi, Dr. Miriam.
Hi, Alberto. How are you?
Fine, thank you. Fine, thank you. How's that pilot license going?
Oh, it's as I was saying earlier, I call it the ultimate social distancing, but we're having to learn things about that we never had to think about since high school, like physics and balancing moments. So lots of groundwork and lots of studying, but it's fun. I'm loving it. Yeah.
Going back to first year, but post your appointment to the board of directors of the Union for International Cancer Control, you mentioned the aim being to bridge the gap between awareness and action in order to reduce the overall cancer burden for everyone. And having had the conversation with a friend of mine who was diagnosed with breast cancer about a year and a half ago, I asked her some questions around the guiding questions that we have today in our conversation. And one of her answers was around surgical care, in that if I had to do this over again with the information that I have now, I don't think I would have opted for surgery. And now we say that surgery is kind of the, it's the best way to treat cancer. But as an active person, having surgery and aggressive radiation treatment, it had an adverse effect on her energy levels and her mobility in her arms and her shoulders. She can no longer really work out in the manner that she wanted to, and it's taken a huge impact on her mental health. And she's now having to go through weekly lymph drainage because she had a lymph nodes removed under her arms. And so, you know, we need that one-on-one and that one-hand understanding on timely access and surgical care, right? On the one hand, in terms of breast cancer treatment, but where is the gap in communication between patients and surgeons, or patients and their doctors and their care providers?
Yeah, thanks a lot. And I think you pretty much painted the picture that quite a number of our patients encounter. And I think sort of trying to backtrack on the key issues that you had raised, one, of course, being the role of surgery. Surgery, as we know, is, we've sort of talked about the bedrock, but what may be interesting to the audience is that, and what they may not necessarily know, is that 80% of all cancer patients are going to require a surgical procedure at some point along their cancer journey. Now, more than a third of these patients may require repeated encounters because, as we said, surgery encompasses the entire patient journey, whether it's from the
We've just lost your sound, Dr. Miriam. If you
You're
could just check
muted,
your sound.
Miriam.
You didn't mute. Yes, we lost you at
to diagnose their cancer, whether it's curative, where we're removing the cancers, or whether it's palliative to support their cancers. We do see that there is a role for surgery. Now, in terms of the gap, in terms of the gaps that exist, as you said, it's the sort of translation. Yes, we know all this esoteric benefits of surgery, but then looking at how do those trickle down to the patients, and this also has implications in terms of addressing the barriers. Zosie talked about people saying that you go to the hospital to die, and sometimes it can be the simple things as a narrative we tell the patients. If, for instance, you say, come in, we're going to press your breast, we're going to try and pick up something, and if there's something, we chop off your breast. If we find a little more, we may have to burn that area, and you're sort of wondering why you don't have a line of people behind signing up for this. So even in terms of changing the narrative or shifting the understanding of the role of surgery and how to best explain it to the patient. And again, it's just the communication. Sometimes, I had this time where I was sort of giving a talk to a support group on the role of some of the postoperative potential complications, and patients were just looking at me with sort of a deer in the headlights. And then later on, they came and told me, you were talking about this fairy tale that none of us can relate to, because nobody sometimes gives us the time to say this is what's going on. I had a 66-year-old patient, lady who approached me later and told me she had an early pre-cancer, and she was told essentially, you have a cancer, we're going to chop off your breast because you clearly don't need it. And she said, who says I don't need my breast? Just because I'm 66, you shouldn't be the assumption that, because I'm no longer breastfeeding or whatever, I don't need it. So even that nuanced approach around how do we put the patient always at the center? And again, it's a simple way about looking about what would I want to hear? How do I sort of walk the journey? How do I put myself in the patient's shoes? I think goes a long way towards addressing some of those concerns.
So let's talk about the situation within the Kenyan context, and what are some of the most common barriers to accessing treatment within the Kenyan context?
Yeah, thanks, Owetu. So in Kenya, we have again, Kenya, like most of the world, breast cancer is the most commonly diagnosed cancer. We've had quite a number of efforts. However, we find that despite a number of efforts, we're still having between 65 to 70% of our patients diagnosed with advanced cancers. And if we sort of look at the sort of conceptual challenges behind that, it's again a constellation of three main factors. One, the fact that patients are having to pay out of pocket. We do have a National Hospital Insurance Fund that has tried to mitigate some of those costs, but it's not entirely perfect. And so what happens is patients frequently get financial toxicity resulting in catastrophic health expenditure, meaning they break the bank. I would say before the National Hospital Insurance Fund, we would have patients coming in. How chemotherapy works, for instance, is you need to have a couple of cycles every couple of weeks in order for it to be effective. And what we would have is, when I was an intern, for instance, patients would come in, have the initial first cycle of chemotherapy and just disappear, and we wouldn't be able to figure out where are they, what's happening. And then 6 months later, they would come back really excited. They're like, "Doc, we've just raised enough money, to support the next cycle of chemo." And by that time, of course, the cancer is growing. So the National Hospital Insurance Fund has tried to mitigate some of that, and we're definitely seeing a lot more patients sort of going through the treatment journey, but there's definitely more that needs to be done. The second broad pillar is part of the challenges that Ben and many have raised as well, given the fact that patients encounter the health system but are either mismanaged. Sometimes patients come in with advanced cancers and they're shamed. They're like, "Why are you coming here? There's absolutely nothing to do. Just go home." Or sometimes they're, inappropriately reassured, "You're breastfeeding."
Dr. Miriam, I think you muted again.
Second broad pillar that affects our patients. And I think one of the key issues that many has raised is around, and Ben as well, is around the social cultural barriers to care. And I think these address things like fatalism that Ben talked about. Again, I think the important areas that also does need to be talked about is, again, the fact that women are not frequently the primary determinants of their health-seeking behavior in many parts of sub-Saharan Africa, and as such may either require either a partner or a spouse for their or permission in some cases in order for them to access care. Again, there is the fact around collectivism where, as Africans, our strength is our sense of community, but it can also be a double-edged sword because people come in and the community says, "We have decided she is not necessarily going to have surgery," or "She's going to have one option of surgery versus the other." And you're saying, "Okay, but what is the agency for the patient? What does she actually want?" And so trying to sift through all those nuances, again, with some of the other barriers that we had raised around stigma, alternative therapies, again, which kind of, and the myths around breast cancers, for instance, and other cancers. Ladies get shamed, for instance, for getting a breast cancer because it may suggest that, you've been, a lady of questionable morals, and that's why, somebody else other than your husband touched your breast. So starting to address all these myths and theories around breast cancers will go a long way towards mitigating some of these barriers. Thank you.
Dr. Ben, are you seeing similar across Africa? How does that compare across the African continent at large?
Well, there was a study that was done just last year looking at Africa and different countries, and it's a very broad spectrum. There's even a spectrum within countries, looking at Namibia and different groups within Namibia as an example. So Africa is not one big country. There's diversity. There's diversity in high-income countries as well. And so that's part of it, is we have to adapt to the resources that are available in the particular situations that will be variable, rural versus urban, one country versus another. Some of the things that we do are very expensive, and some of the things we do are very affordable. And so recognizing that and realizing that sometimes it's an organizational problem. It's not that it's not just pouring money into it, it's organizing ways that you're functional. That is a key principle of what it is that we're doing. I do want to add the role of the patient is something that every country is different, but I trained as a medical student and resident back in the 1980s, a long time ago. there has been a huge transition in how breast cancer is thought about, and it was the women that changed it. It was not the medical community. It was the women organizing into advocacy groups like Susan G. Komen, the American Cancer Society, other groups coming and saying, and they really demanded that things be done differently. Today, breast surgery is a field. There was no breast surgery field back in the 1980s. And a lot of the surgeons are women. And they do understand where this is. And they can understand there are certain areas where there are choices that one can make. There are other areas where the evidence is pretty clear. You can't skip this part. And we actually don't have a way of curing breast cancer, meaning it doesn't come back within her natural lifetime. We don't have a way that doesn't involve removal of the tumor today. Maybe in the future, maybe new drugs, but not today. But sitting with the patient, I would, as a surgeon, when I was practicing, we would spend an hour with one patient going through everything so that she really understood, and we understood she's the driver. It's patient-centric. This is doable, but hard in limited resource environments when there's so few resources and time is hard to come by. It is possible though, and change is possible. Thank you.
I mean, when I talk also about my friend, Dr. Ben, I talk about the fact that if she had a choice, she wouldn't have gone through with the surgery. And she talks about the information that she has now. But then what role does surgical care play in breast cancer care? Do we have a case here of a patient not being included in the outcome versus a patient who is not informed enough?
I don't know the answer to your friend, because I don't know enough about her case, but we actually do need to remove the tumor surgically. We don't have drugs or radiation that make the tumor go away completely in a reliable way based upon modern science. But there are choices. Can you have a lumpectomy with radiation? Do you need to do mastectomy? There are things that we can do so that the patient has more control over what happens. But you were also talking about survivorship. You were talking about after treatment, what happens? Lymphedema, it's a real problem. We have newer surgical techniques that may help us not do the complete node dissection, making these available. These are all things that are driven. But I have to say, the ministries of health, I don't know that they listen to the medical community, but they do listen to the advocates. They listen, especially if you're in a democracy and they're voters, they listen to voters. And so that's why this organization of advocates, and so that the women are talking to each other and they're getting good information. I'm not sure that your friend did the wrong thing in having surgery. I suspect she did the right thing, but she is suffering. And we need to address that suffering in the best way that we can.
So, when I also asked my friend how a patient-centered approach can improve health outcomes for breast cancer, her response was that the treatment plan is very cancer-centric. It's almost as if the human being is taken out of the equation because people's mental and emotional well-being aren't factored into the treatment equation. If they included that instead of just science of eliminating the disease, especially at a time when being mentally and emotionally healthy is crucial for the healing process, it's as if there was no team effort on that account. So she's saying that the doctors diagnosed and decided amongst themselves the best method of action. So
I'm so sorry that she had that experience. I have to tell you, that's not the way my cancer center in Seattle, Washington is. But again, it's because the women demanded it and doing this collectively and said, we need to understand what you're doing and why you're doing it. And the idea of the doctor comes in and says, you get this and you get that, that isn't the way it happens. Not in Western Europe and not in North America. Obviously, there are exceptions, but this is an awareness thing. We can do better, and meetings like this are one way that we get there.
And this is where I want to bring in Dr. Miriam, because this is the lived reality of a lot of African women, right?
Yeah, thanks so much. And I was actually going to jump in as well, because again, we also have to think about when you're dealing, I would say, with vulnerable populations, people who may not necessarily be as well informed, that still doesn't let you off the hook. I mean, the processes of good practice still apply. One, make sure whatever treatment you're offering is understood by the patient, and make sure that because again, we're moving from, the paternalistic approach to medicine that's always been, I would say, in sub-Saharan Africa for, the longest time, where we sort of came down from the mountain with the 2 tablets and told you to take them, right? And that is shifted to, again, what does the patient understand? What does the patient want? And so I would say it is possible to do the same. It might not necessarily be as labor intensive in the sense that we may not necessarily have all the moving parts, but there is no excuse for not explaining to a patient who has given you the privilege of, having access to their body, exactly what you're going to do and what effects and the intended outcomes and subsequent care will be like. So what we're trying to do, again, one of the things that we sort of struggled with in East Africa, and I'm sure it's definitely the same, is you kind of got the treatment based on the clinician you saw. So if you saw a surgeon, before you blink, you would get into surgery, or you saw a medical oncologist and you would get chemo and then probably get sent to the surgeon later. And so one of the key messages that we've been trying to push is just the understanding of a multidisciplinary approach. Like you have several members of a team and you are actually at the center, listening to the team can, yes, sort of huddle together in a little corner somewhere, but ultimately at some point, there has to be that transfer of information. And so what we've been trying to do locally is run what we call a multidisciplinary breast clinic, which involves a medical oncologist, a radiation oncologist, and a surgeon. And basically, we sit down as a multidisciplinary team of what are called the tumor boards and come up with a treatment plan. And then invite the patient and her family, because you definitely need your support system on board, have a discussion for maybe about an hour or so and sort of understand and explain the choices to her and sort of say, what do you think? Where are you coming from? This is the best evidence, but what works best for you? And what we've sometimes discovered is, especially with our multidisciplinary clinic, we've actually seen sometimes a decision-making changes, I would say 30–40% of the time based on what the patient wants. And so people may argue that we don't necessarily have the manpower to do this on a, say, systems level. But again, with COVID, the opportunity and the silver lining has been we've shifted quite a number of these online. So we've had resources that were previously not accessible that are now actually able to be not necessarily there in person, but are able to weigh in. So looking at how do we leverage on this to ensure that these type of patient-centric models are amplified in our different communities in sub-Saharan Africa.
And I want to bring in Zozi here just to have a little bit of some girl talk from, rural girls from the Eastern Cape talk. You mentioned in your opening remark of, the low-hanging fruits being the education, the testing, the treatment information. And that's usually the big thing, right? Dr. Miriam just raised it, in that you get sent to one particular doctor, that's what you get. You get sent to a surgeon, they will cut you. And that's usually what happens around our spaces and in our communities. Is your aunt is going to come home or your gran is going to come home and get told what she needs to do. And then we all sit as a family and we say, is she going? Is she not? Nah, or yes. But we never know what the outcome is. And I know that I'm having to personally, I have to bully my mother and my mom-in-law, for example, for their annual tests and kind of make it a girls' date and be like, we have to go for these tests. We have to check each other out. So, how do you think we can kind of galvanize or create kind of health trends within our communities, within our rural spaces as well, to say it's important for us to kind of educate ourselves, get tested, get treatment information before having to live with the reality of I have cancer?
Thank you so much for that, Oluwatu. I think it goes back to really speaking to people, like I said, in a language that they understand. because sometimes that lack of education is what really makes us scared to, go and see doctors. And I think that's the common thread that I've really picked up from people, especially adding on to what I said earlier on of people having lost that trust in, the healthcare system in South Africa specifically. I don't know about, other parts of the world, especially where I grew up, where there's, lack of resources, there's crowding in those spaces. It's just people being scared and having lost trust. And so I think a better way for us to get back there is to improve our healthcare systems and making sure that people do feel safe when they go into hospitals and know that that is in place, in fact, a place of healing. We're not going there to die, like I said earlier on. But it's basically those two things I think that we need to really hone and polish, making sure that, people in rural areas are educated enough to know that that is where to get help. And the second part is making sure that these places indeed are, safe enough for them to go and feel safe in those spaces. Because I feel if those two things are done correctly, then it won't need to take a lot of convincing, to tell my mother to go to a hospital, because then she'll feel safe and know that that is where, she can get help.
Yeah, absolutely. Dr. Lenetta, can I bring you in here? I want to talk about a patient-centered approach. And if I'm a patient from a low resource setting, I have little to no access to this information or to the resources. What does this mean for me? Because we're often told that cancer is a race against time. So with the little or no information that I know, but time is also limited, and we need to work against time to make decisions fast. And I also want to be informed. I want to know what I'm getting myself into. Where do these two things meet, and how do we mitigate these issues?
Such a difficult question for me. Well, I think you should still realize that you have this voice. So stay strong, and with help of your loved ones, seek help, seek access to surgery. Do not accept delay, seek communication and information. What Professor Miriam already said, multidisciplinary information is there for you. Information is everything. With information, you can come forward and understand why decisions have been made as they are. But I understand, I feel so privileged working in a multidisciplinary team. I also have a multidisciplinary consultation room. I feel so privileged to work where I work. So it's really a difficult question, and I really want to empower patients and future patients with saying, you have a voice, come forward, seek help, seek information. You have the right to ask, always.
Can I bring Dr. Meni in here? I know you definitely have something to say around this.
I do. And I think there was a comment in the chat that near Dr. Mutabi, and I would add actually, as well as Lenetta, are exceptional breast surgeons, are some of the best that the profession has to show, right? Because they understand what matters to patients. They both told us about the emphasis on working in a multidisciplinary team, listening to the patients, and thinking about the patient in their entirety, and not just, a cancer and let's get on. Now, from my perspective, I think the real question is, how can we make more doctors think like this? Because there needs to be a little bit of a cultural mind shift there. And I think that's really critical, because it's only when more doctors start thinking like this that we will see the change. And we will also see, and I know that Dr. Anderson said just a few minutes ago, how women changed the conversation in his experience in the United States. But they changed the conversation because it was in the United States, and because it is a different type of world with a different possibility for women to have a voice and express their voice, right? I live in Europe, where even in Europe, it's much more difficult. It has happened, but it's much more difficult. And I happen to be Greek, so I come from a special country within Europe. So I know, it's a little bit in the south there. It's not too far from Africa. So the mentality plays an important role here. And that is why I'm thinking, if we are thinking about the mentality, how we are going to create this mindset in the doctors. That's where we need to give patients the voice in some kind of structured way, so their voice is being heard. And I'm bringing it up to what UNITAR and myself are working with in Europe, and I think this type of approach of helping patients measure in a structured way what they're doing can actually really help this conversation more, and potentially and importantly help more doctors think like Dr. Mutabi and Linetta, which to me is really the objective. How can we get the doctors, without blaming them, because it's not about blaming, but it's about helping them to see the difference and helping them to see that there is a way to do better. And therefore, because I know they all do want to do good, right? The important thing is to give them the possibility to challenge themselves to do better. And I think that's the same everywhere.
And I mean, I want to stay with you, Minnie, you know, the role then of policy. What does policy do? How does policy play into this in improving these outcomes for breast cancer care then? Research and measuring research and measuring the research impact are critical for policy as well as any philanthropic and government funding agencies, right? So these are kind of informed, and there's a trickle-down effect. It's not just about, you know, having the mentality. It's really the policies and people following through on those policies. Am I correct?
Yeah, I mean, it's at the end of the day, it's quite simple, right? I'm 100% sure that Dr. Mutebi's and her centers and her team's outcomes are much better than this other doctor that your friend was talking about, where she didn't have this conversation. Not because I'm a doctor, because I'm not, I'm a lawyer. We said that from the beginning, but because I have common sense. And the common sense is that if I've participated in the discussion with the doctor, I feel I'm a team with the doctor and her team, not just the doctor, but everybody else, then I feel better about what's happening. I'm cooperating. I am adhering to my treatment. I go to see the doctor when I'm told I need to see the doctor. So the actual outcome is better. So even if the surgery itself is not, 10 times better than the surgery that happened by a surgeon who did not have that conversation with a doctor, a patient working together with the team will have better outcomes than a patient who is outside of the conversation, right? So if we can show, right, with data, how the outcomes in this case are so much better than in the other, I am convinced that any surgeon who works, any breast surgeon, would also start thinking, what do they do that I can do better so I can get better outcomes, right? And as I said, it shouldn't be a blame. This is not a blame game. This is not that the one is good and the other one is better, but it is a matter of how can we learn from each other that we all become better. And then if you get the medical community to start becoming more patient-centered, then I think a lot of other things will also start happening naturally, because even diagnosis will happen naturally because people will be less afraid to go and see the doctors. And so the whole care will change.
And in order to also have more Dr. Miriam's and more Dr. Linetta's in our system, we obviously need the right kind of funding, right? we need the funding, we need the resources. And for the resources to happen, we need the research, we need the measurements. There's a quote here that I pulled from a research paper a research paper in the Cancer Research Funding Program in Australia that says, the main aim of health research is to improve the health of people. Yet the performance of researchers tends to measure by the scientific quality of their research rather than by the impact on health, like you mentioned. So globally, with improving outcomes, how can we take these lessons and these ways that we need to improve our patient-centric healthcare in breast cancer and apply it to low-income and resource-limiting settings and send the funding as well along with it?
But it goes without saying, because I think one of the problems that you have when you have to decide on funding is you need to see that your money goes a long way, right? That's what you need to see. And I think there have always been, and there are a lot of measurements about various types of KPIs, about activities. But what's incredibly powerful is when you actually show improvement in outcomes. And when you show that it's improvement in outcomes also that the actual patients asked for, right? Because then you can see the impact of what it is you do. And I mean, we are human beings. We always want to be thanked or need to feel that what we've done had an impact. And what better impact than showing impact on outcomes, right? So by focusing on outcomes, I mean, by focusing on outcomes, we show that, look, we've not only saved lives, but we helped women continue thriving. As you said, as I said, it will stay with me, not just survive, but thrive. We show how women thrived, how women themselves stressed or explained how their outcomes have improved. So it's much easier to go and ask for funding when you have this type of results to show than if it is something which is, either we spent so much and we did so much surgery. That's not what moves people, right? What moves people is to hear, this is the results we've had, this is what happened to these patients, this is how much better they're doing. And this is how they tell themselves that they're doing better. So it becomes more of a natural process, right? If you show results, then you get more money. And the people who gave you the money, they're happy to give you more money.
And with that said, Dr. Meni, if you could say one thing to the world leaders making decisions on how to direct resources, what would you say?
Patient-centered care. Ask the patients what matters to them and think about how to make things better for the patients. Work with the patients, give them a voice.
Dr. Ben, what would you say?
Well, I could not agree more about the critical nature of patient-centric care. It's how you're going to get participation. But I think we also have to educate our health systems so that they can make what is available and sustainable available through the public system, and advocating for payment for this through universal health coverage or that sort of thing. This is a major goal of WHO. And so I think it's these multiple strategies used together is how we're going to succeed.
Dr. Miriam, something Zosie touched on in her anecdote as well, and in her opening address was, we're often in settings where communication is limited, language barriers, there's the inability to express ourselves, we don't know enough, and medical staff are inundated and sometimes impatient. But it's important to match the timely access that we spoke about and the respect and autonomy of every individual receiving care, right? How do we get that right and start trickling it down to our nurses, to our everyday caregivers, to the first respondent who, if I go to them today and I say, I feel like I've got a lump in my breast, how do we trickle down that autonomy and that respect and the limited communication and education?
Thanks, Alberto. And I think those are great comments, I think, from yourself and the rest of the team. I think it starts basically at the curriculum level, at the training. We're not necessarily going to wait till we, graduate a surgeon to tell them, hey, this is the time to learn about respectful care. If we're able to build these early into our respective curriculum such that it becomes almost second nature. We were actually having the discussion around, can you teach empathy? And we're like, no, it's something you either have or you don't. But we're sort of going back, we realize, no, this is an actual competency that can be instilled, that can be trained, and that can be integrated early on in the health workers training, whether it's as a nurse, as a clinician. I think these will ultimately go a long way towards enhancing some of the aspects we're talking around respectful care, again, also having that, I would say, almost a gender-sensitive lens, because part of the barriers that we have in our setting is sometimes, old lady comes in and sees somebody her son's age and doesn't necessarily want to reveal their breasts or anything. So keeping in mind, even as part of the respectful care, having a concrete appreciation of the nuances of the social cultural barriers that may exist and how to mitigate them, I think goes a long way towards enhancing or amplifying this kind of care. And as we said, you may not necessarily have, in too many hours, but you can take at least 5 to 10 minutes just to explain. And again, you don't necessarily need to do everything, which is where the role of the teams come in. As a clinician, you may be seeing many patients at a time, but if you sort of dedicate, and that is a model that we've seen in the NHS, for instance, in the UK, you have a dedicated breast nurse, for instance, and similar, these potential are able to sort of spend a little more time to sort of figure out what is the patient understood, are there any gaps, and they sort of act as bridges between the patients and the clinicians. And so these are all potential areas that we could sort of start to leverage on. We're already seeing some of the effects of these with patient navigators who are trained nurses who are actually walking the patient through their journey all the way from diagnosis. You have a navigator to ensure that you get the continuum of care. But these are all different aspects that can be leveraged and not necessarily high investment, but can definitely be harnessed for the greater good for our patients. Thanks.
Can I add to what she just said? Miriam, as usual, was just hitting the nail on solidly. When I go to countries, I go as a student, not as an expert. I want to learn how do you do this here? Because they may have problems that I haven't had to struggle with. I've seen excellent examples from India, Tata Memorial, where they were managed to take care of very large numbers of patients and provide high quality care. And it was through organization, like she said. So while the doctor making the recommendations, they may not have much time because the number of patients they see, the nurses and the residents would supplement this, and they were the ones who would spend the time. So by creating workforces that are well educated, you can help alleviate the fact that of the problem, the number of physicians versus the number of patients. But looking to other environments that work, that's how we can I think, make progress. Thank you again.
Thank you. And I think we've gotten down and quite drilled down on, and I love that Dr. Miriam mentioned empathy in being able to limit this feeling that many breast cancer patients have, such as my friend, that it was not a team effort, that doctors diagnosed, they sat amongst themselves and they decided amongst themselves the best method of action on my body. And I had no say in it other than the effects where, yes, I've survived, but am I thriving? I don't think so. And with that, we'll bring to a close our session today and our conversation with just one call to action. We understand that surgery is the foundation of most cancer treatment, especially breast cancer. But we call on civil society and government, as well as personnel from nonprofit and private sectors, to make patient-centric healthcare for breast cancer patients a priority. And I'd like to open up to the panel if there's any last words that we'd like to say before I close.
I love your call to action.
Thank you. And with that, I'd like to thank Zozibini Tunzi, our esteemed panel of experts, Dr. Benjamin Anderson, Dr. Lynetta Coppert, Dr. Meni Staliodo, and Dr. Miriam Mutebi. A huge thank you to the United Nations Institute for Training and Research and Global Surgery Foundation for the incredible work and the ensuring that everyone is included, seen, understood, and are valued in the role of surgery in breast cancer care. How can we improve healthcare outcomes? By ensuring we have a patient-centered approach. Thank you to you, the audience, for your commitment to learning and wanting to see our healthcare system strengthened. Nangomso, have a good afternoon further.
Thank you very much, Aleto, and thank you again on behalf of the UNITAR and Global Surgery Foundation. This has been a fantastic session, and yes, thank you for that call to action, because really without doing it together, we're just not going to reach that target. And on our side at UNITAR and GSF, the Global Surgery Foundation, we are committed to working together with all the partners to to increase access to care, and particularly patient-centered care. So thank you very much. And with this, I'll close the session. Thank you to all the participants, and keep in touch. This will be online, and you can forward the video to your friends who weren't able to watch it, and watch for future sessions. Thank you, and have a good evening.